Our hospital began in 1917 as a hospital for Africans during the colonial times. It has grown from that maybe 17-bed capacity of those years, the general hospital, to what it is now, close to 1,000-bed capacity, and still growing to meet the needs of the nation.
Chandaria Cancer and Cancer Center is our nerve center, really. It's a huge center for supporting our training. It has the administrative offices, it has the treatment rooms, it has teleconference rooms, it has meeting rooms, it has classrooms. The cancer center is there with the radiotherapy is done just behind it. This our CEO sits in this office, the senior administration sits in this office, and this is where the support will come from for our training program.
As a referral hospital and as part of our I-unit part of referral hospital, we meet the needs, the referral needs for the western part of Kenya and the countries surrounding the western parts of Kenya, that's Uganda, Southern Sudan, and occasionally up to DRC Congo.
This is the entry point of the I-unit. This is the first point of call of our patients, the records office, and this is where the entire process of registration of all the patients start. From there, once they are registered, they will pay for the relevant services here so that their files can be activated. And right from there to the triage area through the customer care desk for processing. At this point, this is where the patient is examined for the first time. And this is where visual acuity is done. This is where eye care tonometry is done. Blood pressure and blood sugar for those who need to be done. This is our multifunctional visual acuity unit. Those with low vision, less than 618 vision, will be refracted in the refraction room. From there, the patient will go into the filter clinic with several rooms, several doctors, and this is how a filter clinic will look like at the end of it, with a slit lamp and a medical record system in place. From here, the patient will either be sent to the pharmacy, in which case they'll pick the medicine from the pharmacy right across there. It is important because eye needs are different from the general needs. And because the hospital is spread over a large area, it's good to have a pharmacy that can, or a pharmacist who can explain patients all how to use the medicine and avail all the medicine within one place. And that's what the pharmacy gives us. For those who still need further evaluation, will go to the consultant clinics, either that one or to the other consultant clinic. The third group of patients will go directly to the ward for admission for probably procedures or for treatment in the ward. This is our Elgon ward. So this is the reception at that's the nursing station cum reception at the ward, the eye ward. Like I told you, these are dedicated eye ward, 11 beds for female and 11 for male.
Currently, we have 4 qualified ophthalmologists, 2 with fellowship training and 2 general ophthalmologists. One of the ophthalmologists has more than 20 years experience training. The rest are between 5 and 15. So we have a full faculty in ophthalmology itself. Already we are a training hospital for more university medical school. And we're already training for other fellowships. Yeah, I think EXA is one of them. So we have a huge faculty, but domiciled in the eye department, we are 4 ophthalmologists together with the 7 cataract surgeons and 5 ophthalmic nurses, 1 optometrist and optical technician, among other support staff.
Pfizer telemedicine room. So we can access virtually any teacher, any learning resource worldwide. The display panels are there, and you can see the communication system. This is a room which is expandable because it can be beamed straight to the screens shown on the left, and we can contribute by the connections that you see, the microphones, and there are 4 different rooms here with various capacities, fully internet connected, networked with the other systems. That's a very huge resource, e-granary. It is something that we subscribe to.
We bought and we can update.
And update. We have access to Inari.
Yes.
Wow.
We have a complete outpatient unit. We have 4 consultant clinics. We have a theater with 2 beds and I think 3 microscopes. We have a 22-bed ward. We have a pharmacy. We have an optical shop, among the only few in a government hospital. We have an optical workshop. And of course a fridge for those drugs, Avastin, Soxamedonium, then those that are needed in theater. It's a rare sight in government hospitals. It's a 1988 theater. It's due for upgrading, but this is where we are. The main microscope that we use currently is this one. It's a Lumera eye. You'll find it in very few hospitals. Yeah, but we are lucky to have it for the last 2 years or so. Apart from that, so for smaller cases, when we have a very busy theater day, we can set up or when we have a trainee, can be sitting here as the main surgeon sits on the other side and keeps supervising. Now, being a specialized hospital, we have capability for posterior segment surgery. This machine is a Alcon Constellation 2 machine with capability for pars plana vitrectomy and capability for phaco emulsification, and that's what we are using currently. Apart from that, our capability to do children's surgery or surgery under general anesthesia. These are Mindray fairly new anesthetic machine, yeah, and it makes us be able to do all kind of surgery, right from children, very young children, to adults who need general anesthesia. And to support that, we have piped oxygen on the wall there. So we don't even have what do you call them? Gas cylinders. Yeah, because now we have an oxygen machine system that comes from the oxygen plant right to theater and to the wards. These are operation sets, right, for cataract, glaucoma surgery, keratoplasty, squint, orbit,
We're able to touch these ones because they are not yet prepared for sterilization, but we have many to cover all the fields that we're already doing. This is mainly our machine room, equipment room, where we do most of the procedures. The whole of this is a biometry unit, right from keratometry to pachymetry and A scan. And then, of course, you must use a slit lamp when you're doing biometry. Then we have our visual field machine, fairly automated visual field machine. When we need to do rapid visual field assessment, we usually use this machine. This is our YAG laser machine. This is what we use for doing the posterior capsular opacity excision. Revo NX machine is among the only few machines in the whole country with those capacities. And of course, in a government facility, this might be the only one. It has several functions. The most commonly used function is what we see here, macular OCT.
In the process of implementation of the COESCA residency program teaching plan, will rely heavily on the COESCA curriculum, which prescribes how we should go about teaching the various units. I know the curriculum has 10 domains, including basic and clinical sciences, clinical assessment, patient investigation, patient management, practical skills, surgical skills, community eye health, communication, best practice, as well as management and leadership. And it goes on to tell us how we should go about teaching each of these units. Each of the lecturers is tasked to come up with a teaching schedule for the whole year. For example, if I could refer to one of the courses, which is research methodology, epidemiology, and evidence-based medicine. The unit code is BCS 9, and the title, of course, is research methodology, epidemiology, and evidence-based medicine. The purpose of the course would be to help the trainees get familiar with research process and gain techniques in conducting scientific research in their areas of specialization, which is ophthalmology in this case. There will be learning outcomes, and at the end of that course we'll expect the trainees to be proficient in research, research methodology, epidemiology, and evidence-based medicine. And under each of those, there are things that we expect them to be able to do. Okay, and in doing all that, because of limitation of time, we'll keep referring to the curriculum document so that we implement as accurately as possible. And each of the lecturers is aware of this. Each of the lecturers is aware of the responsibility to prepare their teaching plan for the whole year. This is work in progress in some cases, and the point is we'll stick to the COESCA curriculum and consult where there is need to do so that the implementation process is on point as much as possible.